3. Just a reminder that this meeting is recorded. We will go ahead and do roll call in just a second here. Thank you. A reminder, a couple housekeeping items. Everything said and shared via the chat is part of the permanent recording, and this is shared to the Bureau's website. We'll go ahead and do roll call. Thank you, Shelley.
All right, Brian Smith.
Present.
Chris Salvino.
Here on the phone.
Thank you. Dale Woolbridge.
Online.
Online. Great. Dan Spate.
Yes, here on the phone.
Thank you. Deborah Garambe.
Here on the phone, thank you.
Edgar Bissonette. Bronco's out. Gail Bradley.
Present.
Darth Gamer.
Present.
Glenn Kasperzik. Heather Miller. Howard Reed.
Sorry, I'm still on.
Okay, great.
Thanks, Heather.
Eve Godthinker. Not until Jim Hayden.
Present.
Jesse Torres.
Present.
Rod Reed.
Present.
Roy Ryle.
Virtually present.
Sarah Parati.
Present.
Shari Brand. Phoebe Merrill.
She's present with Heather Miller.
Todd Hermio.
Present by phone.
And Vince Martinez.
Present.
And Vivian Geller.
Present.
You have 4 open, right? Thank you very much. I just wanted to quickly go over a couple items under the chair report, and then we will start with our presentation from Solari. Just a reminder that the attendance report is in your packet. If you missed 2 or more consecutive meetings, the Bureau will reach out to you to determine if you're still interested in serving on this committee. We wanted to share a big welcome to our new member, Jesse Torres, who's the Director of the Governor's Office of Highway Safety. Thank you very much for joining us today. So welcome.
Thank you so much.
We do have several vacancies. We have 3 public member vacancies, a hospital administrator vacancy, physician specializing in emergency medicine from local EMS coordinating region to the Western region, statewide fire districts representative, and 3 largest EMCT employers of EMCT from Phoenix Fire and Tucson Fire. I know several of those positions are just waiting official governor approval. So if you have any questions about your position, if you have put in for that, please reach out to Shelley. She is the point of contact. She will assist with that. We will go back to start with a report that we're going to start off with today, and then a report from Solari. So thank you, Marla. Would you like to share your screen, or would you like Shelley to share for you?
Shelley, do you mind? I can't get it.
Yeah. Thank you. Sorry.
So good afternoon. My name is Marla Rivera. I'm the Chief of Crisis Benefits for Solari. For those of you that don't know, Solari is the state crisis line for Arizona. If you want to switch to the next slide, Shelley, please. We've been doing crisis line, taking them for the state since about 2007, but just recently in October, we got it for the entire state. So we do serve both Arizona and Oklahoma. For those of you that don't know, you might know what National Suicide Prevention Line is, and 988 has taken that over. So it's the same line of business. It's just a different name that makes it more equitable for people to remember when they're in crisis. They can dial 988 and get a crisis counselor that can help out. Next slide, Shelley. Some of our services, you'll see. Okay, great. You'll see that we do take crisis calls. We have a 24/7 peer support line. We have, oh my goodness, you guys, I'm so sorry. This is Andrew's slide, and he's much better at this than I am. Okay, here we go. We have 211 referral, which is more like social determinants of health. It's food boxes, things like that. That's a 24 line under our service as well. We have SMI determinations for the state, and we're just starting SED for kiddos. we manage dispatch and reporting services for the state as well. So though Solari does not contract with the teams that we dispatch out, we do dispatch them out for the state. We have the HMIS system, Housing Crisis Hotline. Be Connected is our veteran support line, and for the state, we also do our DCS coordination for the state for the kiddos that are removed. Next slide. As I was saying earlier, the difference in the National Suicide Prevention Line and 988 is essentially the same service. It's the one thing I do want to bring to your attention about 988, they're still working through this, which is not an issue for 911 and law enforcement and first responders, is that if you have an area code that is not in Arizona, so my mom is a 360 area code, which is Washington State. If she was in a crisis in Arizona, she would go to the 988 center in Washington. So just be mindful when you have those conversations out in the community and you're having people call 988. In Arizona, if your area code is in Arizona, you'll go to us. If it's not, you'll go to somewhere else. Next slide, please. The state of Arizona has done a really good job. ACTS has done a really good job in setting up a continuum for crisis services in the state of Arizona. I do a lot of national consulting on call centers. Solari is one of the largest call centers by volume in the United States. And at current, we have the highest KPIs and metrics for the state of Arizona. We do about 35 to 45,000 calls a month. The unique thing about Arizona is that this has been going on for a very long time. So we have a local crisis number, and that's what people can use that they can bypass that whole issue with the area code being different. So I'll give you those numbers at the end of the slide so that you can give out that number as well. You're going to the same place, but it'll ensure that you get somebody in Arizona when you call. The differences between the different lines, 211 is non-crisis. It will be food boxes, help with electric bills, things like that are not crisis. You elevate up to the 988 state crisis line, and that we are live answers for that line, so you can get directly to a counselor. And then 911, as you all are aware of, imminent risk. That's the difference between those three crisis lines. What to expect when you call the line? We answer both calls and text and chat. We answer in about 9 seconds. We will ask for name, date of birth, but you don't need to give that. So if people want to call, sometimes we get a lot of calls about somebody wants to check on somebody else and they might not have that information, and that's fine as well. Or people just want to remain anonymous and not give out that information. That's okay too. We'll ask if people say they don't want to get that, and that's perfectly okay. We do ask because we are accredited by 2 different bodies for suicidality. Right off the bat, if people are thinking about suicide, if they've had a recent attempt in like 3 months, 2 months, 2 weeks, whatever is relevant for that caller at that time. It's not ideal, I think, for some populations, especially high Hispanic populations or Native American communities aren't really fond of that approach, and I understand that coming from a Hispanic family as well, but that's why we have to ask. If they choose not to answer that question, that's fine. We just have to ask it through our accrediting body. You can remain anonymous, as I said before. Your information is private, confidential, unless we get into an active rescue situation where we feel like if we don't send somebody out right now to help this individual, then we have to give that information to get first responders out there to assist. And then for the third party information, what I do want people to know when they do call the line, there's a limited number of resources. I think we're all aware of that. But if you call and you say, we see somebody on the side of the street, when you see someone on the side of the street and maybe they don't look like they're entirely doing well, you might call and tell us that, but we might not send a team. So the reason for that is some people have the right to not feel well or do whatever they want as long as they're not causing harm to others. But the other thing is that they might not stay in that place. So as I send a resource out to them, they might not stay there to receive that service. We will ask if there's any way we can talk to the person and see if we can gain some approval or some permission to send someone out to give them help so that we can assure that that's actually what they want to happen. So just know that that's the case. Sometimes I'll hear, but we called you guys, you didn't come out, and that would be one of the reasons. And it's usually the the highest reason why we don't pull out. Next slide, Sally. And some of our reasons for calling probably look the same for 911. Depression, psychosis, suicide, anxiety, relationship, social concerns. That's really been big here since COVID. And it's very, it's probably closer to the #1 reason why kiddos call. Self-harm, danger to others, and coordination of care. Arizona's been established crisis line for so long. They've done a really good job not modeling only call for suicidality or an imminent crisis, but to do things ahead of time, right? So if you know somebody's going to be out of meds on Friday, we would rather have them call us on Tuesday, even though they're not in a crisis right now, so that we can help get that set up so that they're not in a crisis on Friday. So a very, very wide range of reasons for calls for us. Next slide. We do publish our KPIs, our key performance indicators, and our stats for both states, Arizona and Oklahoma. And as you can see, this is when you do pull this up on the internet, it's a rolling 30 days. So it's not a month close except for the dispatches. So you'll just see that number roll. In this example, we took 38,000 calls for the month. Our answer rate was 99%, and we answer in 9 seconds on average. Stabilization rate means of all the calls that we receive, how many were handled at that first call resolution, which means we did not have to send a higher level of care, no mobile team, no first responders, things like that. You'll see our dispatches by month. We did hit 5,000, which is the highest we've ever done. So we are really getting people assistance in the community and where they're at. Law enforcement collaboration. Arizona is one of the first in the United States to have really built this out. As you can see in this example, about 2,100 calls a month come from law enforcement. That can be in 2 ways. That can be officers out in the street, or that can be 911 diversion, which means a call came into the PSAP and that call was diverted then to Solari by several means, but one of the more common ones would be just asking the caller, would you like a behavioral health intervention? Would you like to speak to a counselor? Would you like a law enforcement interaction? And so that question alone has really helped divert calls over to let the caller really have a choice in what kind of, because we just really know when we're not feeling good or in a crisis that 911 is going to answer and be there for us. So that's not necessarily always the best interaction to have, but we don't really know as a community how to get anywhere else. So PSAPs have been asking that question. Would you like a counselor? Would you like to talk to somebody else? Or would you like a police officer to be on scene? And so that's really helped get the community a little bit more of an understanding that they have options when they talk. And hopefully 988 will start to get in their minds of 988 the counselor, 911 the imminent response for law enforcement and EMS. Next slide. The crisis continuum in Arizona, this is a national model. You'll see best practices throughout the United States, and they always come to Arizona and say, how do you guys work your model? So all of you that have been involved in that, you know, I hope that you can be really proud to say that you're from Arizona and you have like a state-of-the-art crisis system, because we really do here. So it starts with a person in crisis. They can call 988 or 911. We have statewide mobile team response, which is really awesome because a lot of states don't have that. It can be, you know, really in the metro areas. But we do have that response statewide, and in some of the tribal regions, we've got some co-responding type of situations where we can have a handoff to local authorities to help us out in those situations. In addition, we have some telemed options, which are really great as well too when we can't get out there. The crisis facilities have a no wrong door here, which is really, really great. It allows law enforcement and fire to do like a 5 to 10 minute drop off. So they can get back out to the field to do what they are intending to do and what they're trying to do. And then the drop off doesn't hold them up with paperwork and things like that. And then we have post follow-up crisis services or post follow-up check-in. So the state has said the last touch does the follow-up. So whoever touched that individual last, if it was the call center, we will do the follow-up. If it was the mobile team, they will do the follow-up. If it's the CFU or crisis unit, they will do the follow-up. So it's a really comprehensive good system here in Arizona. And if you ever need to know more about it, I'm sure we're all happy to talk about it more, but that's the crisis system in Arizona. Next slide, Shelley. The overview in the state of Arizona and how this works. 988 is on the side of SAMHSA. So it goes SAMHSA at the top down to Vibrant, who does 988. And then they contract with us, Solari, to do the calls. La Frontera or Impact, some of you might be familiar with, also help us third 988 calls in the state of Arizona. And then on the other side is our REBA crisis line that's been established for a decade, if not more. Actually, it is more than a decade. The state access contracts with the REBAs. There are 3 REBAs in the state. That's Mercy Care, Arizona Complete Health in the south, and Care First up north. And then they also contract with Solari. So either way, 988 or state REBA, you get Solari who answers the call for the state.
To tell everybody what the acronym is for REBA.
Oh, the Regional Behavioral Health Authority. So that's 3 managed care plans for the state of Arizona. Sorry. Right, I got this far without having clarified acronym. This is a good chart that shows the difference. So the green bar is 988 calls in the state of Arizona. If you look at other states, it's reversed, or there are 2 bars. There's just 988. So in Oklahoma, we also are the state there. It's just 988 there. But the state of Arizona has really built up their crisis system. So you can see that 988 really barely touched us in terms of volume here. We still manage 40,000 calls a month through the REBA crisis line, which is a lot of calls, which is a local number that's been here forever and probably will continue to be here forever. There are some differences when you call that line, though you are going to the same company in Solari. When you call 98, there's an IVR system. So you're going to have a little bit of a wait as it will ask you if you want to speak to LGBTQ plus specialized line, and you can go that direction. But when you call our REBA state line, it just goes straight to the counselor. So we do give that out to law enforcement so that they can bypass that triage and get a faster response. Also, law enforcement can tell us, hey, I'm a first responder. And they bypass the triage too. So we'll just send a law enforcement or a first responder to the supervisors who know you're probably asking for a mobile team. And we can just bypass all the questions and the, are you feeling suicidal today, and those types of things. Next slide. This is an example of one of our diversions. So we have several types of diversions that we work with the PSAPs on. This is an example of a MOU and contract we have with the city of Mesa. So Mesa has asked us to take the incoming calls for them when it comes to mental health through diversion, but also their 911 call center, when they divert it through to Solari, they have hired a dedicated dispatch. So they will go directly to their own dispatcher at Solari, and then Solari will dispatch a dedicated team for Mesa, which gives them a faster response time. This is, I would say, the Cadillac model, and then there's all kinds of different models along the way, and that's not for one is better, one's for worse, but it really depends on what each city has and what supports them the best in what they're needing for that collaboration between behavioral health and in 911 and first responding. Next slide are some of the different lines that we answer, some of the things that you can give out to the community if that helps in the areas that you work. The Team Lifeline, we do answer the Team Lifeline 24/7, but they themselves answer their line from 3 to 9. And that's a really unique service. It's managed by teams and it's overseen by licensed clinicians, but it's a real community type of call line, and it allows them to speak to each other in a manner that I think is very supportive. The Warm Line is a non-crisis line, but it's supportive so that if people are, I would say, lonely or needing help maybe with some of their clinic, navigating paperwork, things like that, they will call our Warm Line. And that's staffed by peer support specialists. So those are individuals who have had experience with behavioral health in their life and the behavioral health system, so can help with some of that paperwork requirements. Things like that. It's just a non-crisis line. 211 Arizona is our next step up from that. So that's much more directive. It's, I need help with my electric bill. Like, I know what I need. This is what I need help with. So that is a non-crisis line as well. And then our crisis line, which is the line that I've been addressing with you all here today. All of those lines are 24/7 except for the teen lifeline. When you have the teen, that's just from 3 to 9, but then it kicks over to my staff 24/7 after that. So there is somebody that always. That's an overview of Solari. I don't know if any of you have questions. I know this was primarily, I believe, a first responder meeting. So if there's questions that you have that are directly related to that, I'm happy to answer that. You know, fire is able to call as well and just say, hey, I'd like a team out here. We've cleared the scene, everybody's good, but I think this team can have some more support, and we can also ask our supervisor and we can send a mobile team out for that as well.
Thanks.
Sure.
Go ahead.
We were looking at adding something similar to one of our behavioral health protocols as an additional thing that they could offer. They had no medical issues and it really was purely behavioral. Is there a way, we're down in Southern Arizona, would there be a way to talk to anyone about just getting a little bit more details about what mobile teams may be dispatched in our areas and things like that, just so we could provide some education to the providers about what would be showing up if they did call or refer someone to this line?
Yeah, absolutely. I can grab your information, or Andrew, our president, Larry, uses the information at the end of the slide. I can contact you, or you can contact him. We'll be happy to do that. We're actually in the Tucson Police Department. I have some staff members that take calls in there. So I have a local representative that can help you there.
That'd be great.
Sure. Yeah.
Thank you, Marla. And just to kind of highlight the reason we asked Solari to come present, we have two separate work groups that have convened up from EMS Council. The one was looking at alternative destinations for behavioral health patients. The other was ambulance safety. And in specific regards to the work group for alternative destination, we realized that there was really an opportunity to kind of advertise all the work that Solari does and how that can intersect more with the EMS community. I think Arizona, you shared the last meeting just how much law enforcement works with Solari. There hasn't been quite the same uptake with EMS and fire working with Solari. And so we really want to advertise, to Amber's point of kind of looking at what services are available, what is the crisis response unit, because I think the more we get the messaging out there, the more both the EMS provider as well as the medical directors will feel comfortable. A couple highlights that I have from your presentation I wanted to really call out was that 88% of calls that come into Solari are stabilized over the phone, which is pretty impressive. So that means 88% of calls, no one gets sent out. And I think you had shared before the number, the remaining do get someone sent, whether it be a crisis response unit or EMS, but the numbers that were sent by EMS are very small. And typically when there's an acute emergency, something that's identified as either there's a weapon on scene or there's some type of ingestion or attempted self-harm. So it really does a pretty amazing job of kind of diverting patients from the 911 system. The other thing that I think you had shared at the last meeting was if a EMS agency calls and says, I'm a first responder, you bypass the kind of screening question, but also the goal for Solari from access is a 30-minute response for a crisis response unit. So for EMS agencies, know you've got a 30-minute response time. That is kind of the expectation from access for Solari for the crisis units to get on scene to provide you with that backup. And we had talked about some opportunities to kind of connect even by phone. If just say there was going to be a longer response time where the crew didn't want to wait as long, is that they could potentially connect the patient on scene with Solari by phone to help bridge that. So a lot of opportunities to kind of help expand the system of how EMS intersects with all the work that your team does. This one's an insurance-based service. It's free for anyone. We don't even ask about insurance. So it's just about getting the right help to that person at that time. So there should be no barriers with that question as well. Any other questions for Marlo? Shane, awesome. Jim, go ahead.
Yeah, just two quick questions. Can you hear me okay?
Yes, thanks, Jim.
First question is, I noticed on one of the slides you said text messages or you could call 988. So can you actually text 988 and a text message from any phone as well?
Yeah. Yep.
Excellent. And my next question is, you mentioned early on that the area code is the determination of who is going to be answering the phone. If you have an out-of-state area code on your cell phone, that out-of-state provider will be responding. I'm just curious, because of the 911 system and how PSAPs work, even though you have a out-of-state telephone and you call 911 within most of Arizona, based upon the system, it's able to pinpoint your GPS location to be in Arizona versus this area code that you're from. I'm just curious if there's an ability to work with 911 and in any alleys to equip the system to be able to be the closest location versus the area code.
Yeah, and that's a much bigger conversation. It's much bigger than Solari, but they are working toward that because it's a fundamental issue because even CSAPs can't 3-digit dial. So when you have states that only have 988 as an option, they can't reach their local call centers, which isn't, helpful. It is a funding issue down the way. Different states fund 911 in certain ways. So there is big national talk about that. So I think we'll get there. We're just not there right now.
Okay, thank you. That's it.
Any other questions or comment?
It's gonna be elementary, but so you have to dial 602-988.
No, you just call 988.
But yes, but I mean, the out-of-state folks with the out-of-state phone number, would they dial 602-988 or no, not at all?
No, they would just call 988. It's the call routing that will know it's the 602 number.
Okay, so they wouldn't be able to get to you anyways. It'd have to go through Washington and then would they connect them down here? Or that just wouldn't happen.
The procedure is they would rather not have a transfer like that, just for the sake of a best experience for the caller. But we do have a website that we can go to and say we have an out-of-state caller, and we could say, Mr. Torres, it looks like your state does have a mobile team where you're at. Would you be okay if I transferred you over? Like, if I could see that you would have a better service, if I could get you over there, we can try that. But we try to handle the call as we have it, clear the imminent safety concern first.
Okay.
Yeah, sure.
And
You mentioned that you try to capture name and date of birth. And I don't know if you asked, they won't give you your date of birth. They have, a general age range, but your dashboard did not have like what age groups tend to use the service. Do you have that information anywhere? Or?
We don't have it anywhere public, but Access does, they in our managed care. So and then they do get that information. It's just that we pick the most common questions we get for the dashboard and publish that. But I would say for really, it's just that mid-range of like 20 to 40 that use the line the most. And we do see seasonal differences in that. Like we'll see that mobile teams are really highly utilized during school time, but when they're on break, it really drops. Like there's really seasonality to crisis work, even though you wouldn't think so, but there is. I would say majority is that, and it may look different in different areas. Arizona does such a high level of community or stabilization that isn't. So I think that is why it's so big in that one.
Amazing. Thank you. We can hear you.
is there a question on the phone? Thank you. Any further questions from Marlo?
Yeah, actually, I do have one more question. I'm sorry, it's Jim again. For those rural communities in the first responder world that don't have resources available to them for a resiliency program, let's just hypothetically speaking, a rural area, an EMT has a really tough call. He or she gets done with that call, and they were able to reach out to 988. Do your facilities have the ability to route those individuals to maybe specific individuals that could help them because of their particular background, or is it just kind of whoever calls in gets the next person calling?
I think if I understand your question correctly, well, I'm sorry, Jim, I don't know that I understand it exactly, but in the rural areas, if EMT goes out and decides that caller could benefit or that individual could benefit for a behavioral health service, they just either call us, and in the rural areas, we tend to do face-to-face, which is that individual will go to like the guidance center or somewhere like that, and they got a specific room where we can dispatch then somebody that could get them closer. Otherwise, we can do the entire intervention on the phone. I don't know if that's answering what you were asking.
And I apologize, it wasn't. But go ahead, Gail. I think you know what I was asking.
I think what Jim is asking about specifically for an EMS provider, if it's an EMS provider who maybe had a tough call and they wanted to speak to someone to help themselves in kind of managing and processing, is there a call taker that's specific for first responders that they can connect to through 988?
Well, and that's a great question because we do also take calls for Bulletproof and Firestrong, if y'all are familiar with that. So they could call Firestrong and get a peer-to-peer conversation. We can help connect that, or we can take that call as well, but it would be the same number. I can give you, Dr. Bradley, the Bulletproof and Firestrong information. They also have a really, really great website for Firestrong that shows like who you speak to and who's available to help in the different areas. It's a really unique service. I think it's really beneficial for this community to know about that, but we would take that call and help facilitate that as well.
Thank you. Did that answer your question, Jim?
Yep, perfectly. Thank you very much.
Thank you. I think in the interest of time, we will move on, but thank you very much. I think this was a great discussion. We really appreciate you coming back to present with this group today. I think we shared your slides after last time. Are you comfortable with us sharing it again? Yeah. Okay, so we will share the slides that after the meeting later today as well, Laurie. Thank you. Thank you. All right, back to the chair report. Just a quick update on the naloxone leave behind. I have some show and tell for those of you that are here in person. So this is our finalized version of the naloxone leave behind kit. This is what, if your agency participates, you will get, which includes the 2 doses of intranasal naloxone. It also includes the resource card on how to identify an overdose and how to administer the naloxone, and then a resource guide that is specific to your area. So it's going to be county specific, and with Maricopa County, we have broken into 3 sectors: East, West, and Central, just because we know from the geographic size. The program is live. We have several agencies that have started implementing this to have the kits, and we have several other agencies that have started the training with their personnel. If you have any questions regarding participation in the program, a point of contact, Julie, is at Adam for right now.
Yeah, Adam or myself, I'll put our email.
Julie will put contact information in the chat to reach out to you if you have any questions. I just wanted to again say we are live with the naloxone leave behind. We did send out messaging via Gov Delivery, and we have seen great uptake in the program so far. Next item for discussion, it's just a proposed meeting schedule for next year. We really do try to make sure that we do not have anything that overlaps a major EMS conference, a holiday. We recognize that there are a large volume of conferences across the country, so sometimes we can't avoid everything, but we do our best. If for some reason you see a significant conflict, please let Shelley know and we can reassess the schedule, but we have hopefully addressed that as well. Next, I will move to the Bureau report and Chief Garcia.
All right, good morning. Let's see if these slides work for us, Shelley. I'm going to go very briefly through some of our updates, and we will share out these slides. We have an updated ADHS organizational chart we wanted to share with you all to let you know where the Bureau is located within the organization. Moving through these as quickly as we can. You can go ahead and skip over that one, Shelley. Since these are some of the slides from our STAB report, we'll share these out, but I won't cover them in detail. One of the things I do want to hit on here, though, is that we have within our appropriation this year been able to continue our work with the 4 regional councils, including support specifically for rural paramedic training programs. We're very, very excited about this and hope to continue to hear updates from the region as we meet regularly. We are also working on our EMS and trauma state plan for 2025 through 2030, and we're excited to share some more information with you all about that. Going through the next couple slides, we want to keep giving you updates on some of the most recent legislation. Several bills are scheduled to go into effect January 1st, and so we'll continue to provide updates to EMS Council and our other committees on bills that impact EMS. On the next slide, there is a summary of House Bill 2609, which I know many of you have seen repeatedly, so we'll just continue to include that in the packet. Rulemaking updates is where I'm going to pause for a minute and just make sure that we are sharing with you all an updated timeline. It's been a very busy time for rulemaking in terms of EMS and trauma here at the department. The best practice is that we review rules every 5 years, and all of our rules were ready for review. So now we have some updated rules to share with you all. You know that most recently we've visited EMS scope of practice and air ambulance rules. Our new trauma rules went into effect September 18th, and we are currently in the rulemaking process, as you all know, for ground ambulance, with the goal date of getting those rules into effect by January in alignment with the new statutory requirements. The next set of rules we're scheduled to look at will be our certification and training rules. And again, that's to align with statutory requirements. You can see here on this slide the updated ambulance rulemaking timeline just for awareness. And our goal is to continue to be transparent and share with you all what that process and the projected dates look like as we move along with that particular rulemaking. We can slide through a couple more slides here, Shelley, and keep going. September is Suicide Prevention Awareness Month. We just had that excellent presentation from Marlo with Solari, and we learned a little bit about 988 already. Certainly our goal here is working to reduce the number of suicides in Arizona to 0. I am thrilled to learn, based off some of the questions, that 988 you can now text. So we're coming a long way, and we'll continue to share out resources throughout the month of September. Our next slide is on preparing for November Crash Responder Safety Week. Certainly, we know that the EMS and trauma system plays a significant role in what we call the safe system approach. On the agenda today, we have teed up some updates from our ambulance safety work group that convened here in the last month. And I think it's so important that we consider how do we take recommendations from our work groups and EMS Council to put out effective messaging when it comes to some of our health safety awareness month, especially with Crash Responder Safety Week coming up. We'll keep going. We have an update on SHARE that I'll ask Julia if she would like to chime in here and share a little bit about SHARE.
Sure. Yeah, so we're still in the process of migrating the databases from the University of Arizona's ADHS. Eventually, we'll be able to send out some communication with how to log into the new system. We'll have, well, not the login won't change, but the website will change. So we'll be able to send some information about that soon. We have taken over all communications with the hospital, so please bear with us if there are any delays in any responses or as we kind of try to figure out how to answer some of the questions that you have. That's all I have.
Julia. Our next slide is some national registry updates that we want to continue pushing forward. I'll pause for a moment just to see if TJ McKay is on the line.
I am. Good morning. I'll try to go as quick as I can here. The stakeholder meetings ongoing with the National Registry website. So if you've noticed, it's been down pretty frequently over the last several weeks. Hopefully that will be finished soon. Scaled reporting on September 1st, it transitioned completely from getting the domain level results and the new scaled reporting just to the scaled reporting. So it's going to give students a better idea of how they performed on the test rather than the below, near, and above passing results that they used to get in the old days. A reminder that the new exam, the one that's based on clinical judgment, is going to be going into full effect on July 1st of 2024. And the traditional psychomotor for National Registry will be sunsetting completely by June 30th of 2025. The NCCP is ongoing in its changes. The number of hours overall are going to stay the same, but the number of hours per topic are going to be changing and updating. If anyone is interested, Mark Terry put together a pretty comprehensive podcast, about 9 episodes. It's available on the National Registry website. The other update is something that goes with COAIMS, NASEMSO, and a number of other organizations. We've been working on workforce and some of the results that we've got for some of the numbers, attrition rates. They just completed a study and published it recently. Looking at the attrition rates in programs, we've been losing about 20%, 21% overall to attrition, folks that are not completing the paramedic programs. We didn't really have a great way of measuring that with our old database system. And this is a project that I started working on well before I started with the Bureau. In Arizona, we weren't really capturing those numbers. So when we implemented the image trend system, now we have a way to enroll students into the state database earlier in the program and actually have the ability to now track those that are withdrawn or do not complete the program. The numbers that are associated with that are pretty significant, in addition to the ones that are not obtaining National Registry certification. So we lose about a third nationwide on the medic side from students that are not completing the programs or not passing the test. We do a little better in Arizona. Over the last 5 years, we've only lost about 5% of the paramedic students who do not successfully obtain National Registry certification. It's about 3% that don't pass it within their attempts that are still eligible for a retest, and about 2% that don't complete the testing within 2 years. But in numbers, that only rounds down to about 118. The EMT level is where we've got the ability to potentially capture a significant increase in workforce. Over that same 5-year period, the EMTs, we've had about 20% that either did not pass within, they're eligible for a retest, or they did not pass within the 2 years. So that equates to about 2,200 individuals. So one of the items we're looking at specifically with individual training programs is trying to address the number of students that they have that are eligible for retest and trying to get those folks into the workforce by encouraging them to take all their attempts and helping them along the way, identifying those weaknesses, which hopefully the scaled reporting results that we're getting from National Registry now will help us do. And that's about all I've got, unless anyone has any questions.
Thank you, TJ. Appreciate the update. We just had a quick question to cover EMS and trauma online portal update. One of the questions that has come through to us through previous meeting is to continue to share updates, especially as it relates to the public lookup feature. I don't think we have any specific slides on this. You might be able to go to the next slide, Shelley, just to give a couple snapshots of the online portal. This is how you hit it. It does include a public lookup feature. There is data that is still being migrated to the new system. And my understanding is that all historical data is now uploaded or will be shortly as we're working with the vendor. So if there are any additional questions as folks learn to navigate our new online portal, please let us know and we will continue to provide updates on this as we roll out the new features at this website. I think that covers most of our updates. Dr. Bradley, can I turn it back to you to cover EMS and trauma data dashboard?
Absolutely. And I think, Brian, your question, which had been asked about any disciplinary actions, those should be public facing now.
It did, like a week ago, it wasn't. It had a line that said actions, but nothing populated. But either Thursday or Monday, I checked and it was populating on the people, some people I knew just to be able to check on. So
Yes.
seems to be working. But some dates are messed up like really badly in it, but I could at least see the action. But there are some really strange dates on one of them for sure. So I don't know what's going on there.
Thank you. We are going to continue working with the vendor on that, and we appreciate you doing the spot check there.
All right. So I just wanted to quickly cover our dashboards. Volker did an amazing presentation this morning on the new STAB trauma dashboard that should be going live October 1st once approved at the director's office. So just wanted to quickly remind everyone that we have a number of dashboards available both for EMS and trauma, as well as our real-time data dashboard that updates with kind of real-time 911 calls for motor vehicle crashes, stroke, STEMI, cardiac arrest, et cetera. So just wanted to quickly cover that. We have a pretty full agenda today to remind everyone that we do have the data quality section on our Bureau website, and there is a large volume of data that's available, which is really in a nice format now that it's easily searchable and can be filtered for what you're looking for. So just a very brief overview and highlight of that. Next, we will move to standing at committee and regional council reports. For Cheppy, I know we have a vacancy for a representative that we will hopefully get to vote on later on today. Sure, thank you, Shelley.
The last TEPI meeting, they approved their minute. Noreen explained the survey and that prior to RFP process. Julia talked about the workforce needs survey and strategic planning. Thoughtful, displayed some dashboard data at that meeting. Gave share update. The bylaws were approved as amended. And then Rachel touching on the rulemaking process as well.
Thank you, Brian, for education.
All right, at our July meeting, we approved the minutes. Julie explained the next steps for the workforce needs survey and strategic planning. We approved a work group to create fall prevention training for EMCTs. They had their first meeting on September 14th, and there will be another one that has yet to be determined. We approved our bylaws with some amendments. We approved a work group to update the PED seizure training. They met on August 29th. Approved a work group to create PED airway training. They met on August 30th. And Chief Garcia showed slides for the rulemaking process and the next steps concerning the ground ambulance rules.
Thank you, Brian. Next for PMD update.
We approved the minutes as they were presented. There were requests to add antifungals and antivirals to table 3, which is the interfacility transport list. Both of those failed. There was a request to add octreotide to table 3. That was approved. That will be going to MDC this afternoon. There was a request to add acetylcysteine to table 3. That was also approved and will be going to MDC. There were drug profiles for octreotide and acetylcysteine. Both of those were approved. There were some amendments that'll be going to MDC this afternoon. The bylaw review was tabled for that meeting, and Chief Garcia showed slides for the rulemaking progress and next steps. Next meeting will be November.
Thank you, Brian. All right. Before we move on to the regional council, I just realized that we had not introduced our 2 new staff members. I wanted to introduce both of our 2 new staff members today at the Bureau. First is Erin Henderson. She is our paralegal project specialist, and Mario Manji, who is joining us as an epidemiologist 1. So welcome both to the Bureau, and thank you for participating with us today. So wanted to make sure I covered both of your introductions to the team. Next for regional EMS council. For Central Region, Roy, I know you guys shared this in writing. Is there anything you would like to highlight?
Nothing in particular, Dr. Bradley. I do want to just mention that we are in the process, it seems like everyone else, of reviewing our decade review of our bylaws. And we will be slightly, or at least it will be proposed to slightly amend the members of the Central Region Board to include a representative from a tribal organization, as well as adding an air ambulance representative on the board of AIMS. That's proposed. The executive committee has worked through it, and it will be going to our board at our next board meeting. Other than that, Peggy has a very comprehensive report available as that you can see for your review.
Thank you very much, Roy. Next for Southern Region, Sarah.
Good morning. Thank you, Dr. Bradley. I don't have anything in addition, but I'm happy to take questions.
Thank you for sharing the summary.
Oh, there was the activity event.
Yeah, I just wanted to highlight the EMS on the Desert Conference that was recently had because we had some pediatric education that we had some help with from DHS.
Thank you. All right, next, Vince for Northern Region.
Afternoon, or I should say good morning still. I submitted the names report for anyone who would like to read the highlights of our recent names activities, and there it is. We had our general meeting on August 4th. We also submitted our budget to the state, and names would really like to express our gratitude for that second round of that $100,000 EMCT money, which we will use for our paramedic education in the rural areas, just as we have done in the past, to spread it out among as many paramedics as possible, as well as our gratitude for that $9,000 in EMSC funds, and we plan to use that for our 2024 NAMES Pediatric Symposium. Just a reminder that the Tuba City EMS is presenting their annual Way Out West EMS Conference on October 11th and 12th at Twin Arrows Casino. And our next NAMES meeting will be November 3rd, 2023. Thank you.
Thank you, Ben. Next, Rod for Western Region.
Okay, so I would first like to echo Vince's words on the EMCT funding and the additional EMS for children funding. We are, as the others have alluded to, working through the procurement process to get to those funds, and have a lot of things waiting in the wings when the funding becomes available. Our last meeting was July 6th in Pine Lake, and our next meeting is November 9th in Yuma. And we will be doing our strategic planning with the Bureau and a ton of other stuff that day. So it will be a busy day. And that's all I have.
Thank you, Rod. Next, Dale for PACES update.
Yeah, hi, thank you, Dr. Bradley. PACES, we had our last meeting July 20th. Unfortunately, that meeting did not have quorum, so the voting items will be shelved for our next meeting. We do have 13 members and no vacancies, so for anyone on the meeting who is a member, please pencil in our next date, which the next meeting is November 16th, and we'll be able to move forward with our voting items. And our last meeting was informational only, but was able to discuss a variety of things, including upcoming discussions on the respiratory surge plan, which will be repeated in our November meeting for ongoing discussion. Our work groups remain pretty active. We appreciate the opportunity to work with the Education Committee, more recently that on pediatric seizure module and the pediatric airway module that committee's been working on, and again, appreciate our ability to participate in that. Upcoming work groups will be that of working with the Arizona Department of Education, the Health and Prevention Program, and reviewing their emergency guidelines for schools. That's a work in progress, and we'll be giving an update on that at our November meeting. Beyond that, I will paste in our chat opportunities for training for neonatal resuscitation. Thanks to the Bureau, this will be free to paramedics, and I will paste a link for registration or applying for that in the chat in just a moment. Well, I guess lastly, I was asked to repeat an announcement of an upcoming event, and that's a pre-hospital care conference. It'll be occurring in Chandler, hosted, my understanding is by Phoenix Children's, and that'll be on October 30th. And I'll close with saying our next meeting is November 16th, and I look forward to anyone who's able to join us. Thank you.
Thank you, Dr. Woolrich. All right, next we will move to our discussion and action item. If I can get a motion to discuss, amend, and approve the EMS Council meeting minute.
So moved.
Thank you, Brian. And a second.
Second.
Thank you, Roy. All right. Any recommended amendments to the meeting minute? Hearing none. Anyone opposed, please say nay. Anyone, any abstentions? All those in favor say aye.
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 Next, we need to nominate and approve a new CHEPI liaison. I believe we did get a nomination before the meeting for Dr. Stevie Merrill. So I need a motion to nominate and approve a new CHEPI liaison, please.
So moved.
Thank you, Brian. Can I get a second, please?
Second.
Thank you, Ben. So we do have Dr. Merrill, who is nominated as the liaison. We can also accept nominations from the floor if there's any other nomination. I will pause briefly to see if we have any. Hearing none, anyone opposed, please say nay. Any abstention? All those in favor say aye.
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 Excellent. Thank you, Dr. Merrill, for being willing to step up for that. Next, we're going to discuss some updates from our Behavioral Health Alternative Destination Work Group. If you can share my slide, please. So we did have our first work group meeting in August, and we have another meeting coming up on Monday. I wanted to just share a brief one-slide summary of kind of some of the work that we, I think, did accomplish. We had a really nice presentation from Solari that you all heard again today. Kind of the three key elements that we had at the first meeting were talking about, number one, the ability, can EMS transport directly to behavioral health facilities? The answer is yes, with the rule and statute that delineates this. Can EMS bill for transport to behavioral health facilities? The answer is again yes, with the revised statutes attached. And then can EMS agencies get paid for these transports? And again, we have that yes with an answer with the statute based on the funding and rate that Access is statutorily contracted to reimburse at. At the meeting, we had quite a bit of additional discussion about kind of what the work group goals are. Our goal for this work group is to really keep the scope specific to EMS. We recognize that there's lots of different avenues and discussions for alternative destinations that can extend beyond behavioral health. There's also things related to interfacility transfers and issues along those lines. But we wanted to really limit the scope of this to kind of the topic of diverting patients from the ED when possible. So we have our follow-up meeting on Monday. Access will be presenting in conjunction with their crisis stabilization team and Solari. We do have some commercial insurers that will be listening in as well, and participation from a hospital association. So I think we're making really good progress with this work group. Next slide, please. The second work group was looking at ambulance safety. We had just a brief recap. This meeting, the question is kind of looking at trying to figure out the scope. And so at the end of the meeting, I think we came to a few main goals, which are really looking to see, should we make a recommendation to decrease the number of code 3 responses / transport, recognizing that our goal is to improve safety for the EMS providers as well as the public. Also looking at potential public safety campaign addressing safety around emergency vehicles. Specify some level of minimum training required for ambulance operators, and sharing resources for emergency vehicle operation training courses across the state. So those were to date some of the recommendations that came from that work group. That work group will be reconvening next Thursday as well. The meeting announcements for both those work groups did go out with the meeting announcements for today's meeting. So hopefully you have those. Just wanted to see if there's any specific questions or feedback. I'll start with the alternative destination for behavioral health first, and then we'll kind of move over to the ambulance safety next. Any questions or feedback regarding the work that's come out of the behavioral health alternative destination work group so far? All right. Hearing none, next we will just have any discussion or feedback on the work group on ambulance safety.
That's did go out with the charge statements.
Yes, please. So one of the things that we did share, this is a joint position statement that is looking at life and plans of vehicle operations and emergency vehicle responses. This was published in February of 2022. If you scroll to the last page, you can see the endorsements from the various national organizations really looking at how do we address the safety when we look at our EMS responders out in the field. And so really our goal of the Bureau is trying to figure out how we can help support this at a statewide level, recognizing we want to support the safety of our EMS providers as well as the safety of the citizens of the state of Arizona. So I wanted to just briefly make sure we included this position statement for any areas of the state that there's maybe been some questions about why is the Bureau talking about this. what's the importance of potentially decreasing your lights and sirens responses. I think this is a very nicely written position statement that addresses that. Yes, Brian.
I'd kind of like to know, after 2.5 years of dealing with response time subject over the ground ambulance rules, how that jives with the debate over response times, both and now including inter-facility transports, particularly emergency inter-facility transports, because there's a huge disconnect, I think, between the discussion that's been going on over that topics, and especially with any new CON or amended CON, they're going to have to meet that 90% of the time. And it just seems to me that there's a big disconnect, and it's going to take some time now after dealing with this for 2.5 years from a 5-year review initially, besides the 2 bills that are going to have to be addressed in the rules. So how do you plan to look at that?
I like that you bring it up, Brian, because I think it's important that we acknowledge a position statement like this as we move through the rulemaking process. What the rulemaking is laying out is measuring response times for both emergent and non-emergent responses. And so there's that opportunity to really make sure, are we measuring response time within the requirements of the new legislation that's going into effect in January? And are we providing safety recommendations that are also in alignment with the national statement that we're seeing? So I think the timing is really right for it. I know that there's been a lot of discussion about response times, and this really just emphasizes how important it is to make sure we're looking at both emergent responses as well as non-emergent responses, which many folks will say code 3 versus code 2 responses.
I see Vince has his hand out. Vince?
Yes, thank you. Yes, kind of echoing what Brian just said. I think this part of the meeting, I would like to see it discussed further. I think that safe response in all areas, emergent, non-emergent, is very important. And in light of Article 9 and our response times and the work we've been doing over the past 2 years, 9 months, it's important to really define these terms. I think right now in the current draft rule, we have the basis for what could be a safe response as what is being proposed by DHS. We just need to take it a step further. And I appreciate, Rachel, that you're planning to meet with us and discuss this further. But I would like to see us take a look at that safe mode of transport or that safe mode of response to the scenes. Thank you.
Thank you, Vince. Any further questions or comments? Well, again, thank you for everyone who has participated in both of those work groups. I think these are 2 really big topics in the state of Arizona. I really wanted to try to address some of these bigger items as kind of are emerging from COVID. So if you're interested in either one of those topics and you do not have the meeting information, please reach out to Shelley. She can make sure that you have the information for that. Those will both be a hybrid format, so either in person or virtually. So if there's no further questions, we will move on to the next item, which is the Arizona EMS Trauma Needs Assessment and Strategic Plan, and I will hand it over to Julia for that. Thank you.
And can I help segue into Julia's topic? I think coming off of there are discussions about ambulance safety and Article 9, looking at rules, it really emphasizes the need that as we're looking at updating our administrative code, we are really looking ahead. And we want to make sure that we're capturing many of the important subjects that come up during the rulemaking and incorporating those into the 5-year plan as we look ahead. And we're so appreciative of all of the stakeholders that have participated both in the rulemaking process and now as we transition to the needs assessment and strategic planning. Big thank you to Julia and the services section team for developing the needs assessment and beginning to work with stakeholders on this, because we know after having so many of the discussions we're having here today, such an important process. So Julia's big thank you, and I'll hand it over to you.
So yeah.
Dr. Hudson on the phone? Nope. Okay. Well, so yes, as Rachel mentioned, we have completed our survey parts of the needs assessments in the process for our strategic plan. And so now we are in the focus group component. So we're really hoping to have kind of focus group discussion meetings with multiple stakeholder groups, reached out to the regional councils and some other groups and hoping to get something on the calendar. We did have our first meeting yesterday with AIM in the central region. And that was great. Really what it looks like is we'll present some of the results from the needs assessment survey and then ask for additional feedback through a polling software. So really big thanks to AIM for letting us come to your meeting yesterday. And we're looking forward to some of the upcoming focus groups. You can definitely share those out if you're interested in participating.
Thanks, Julia. Next item, if I can get a motion to discuss, amend, and approve the update to the bylaw. Thank you, Brian.
Second.
And I guess I didn't catch that. Sorry, who was the second?
It's Dale Woolridge, second.
I'm just monitoring.
All right.
I'm muted.
Oh, regarding Dr. Finn.
Thank you. Dr. Gamer, you are not on mute.
Just
Invoice
separate
separately,
invoice, yeah.
just like number it.
Started with 500 or something.
Let me
Okay.
see if I
Or
can
totally
find
different.
here.
Okay.
Or take like one of the ones you've already done and then.
Thank you. All right. So in terms of the bylaw update, we had a first and a second to review. The proposed bylaw updates are in red. I will briefly cover the recommended updates on page 2. There are two components. The first component was talking specifically about that members of the council appointed by the governor for 3-year terms or until the position is filled or replaced, whichever is later. We recognize that sometimes individuals on EMS council will have an expired term for quite some time. It is outside of the Bureau's control, but we wanted to make sure that we can maintain quorum. The second component of this is also the requirement as part of our public facing meeting that there is a law 2000 or standards of conduct for boards and commissions training that does need to be completed, as well as a loyalty oath. We requested that this be added to the Bureau because to the bylaws because we have had issues with getting everyone to complete that. So the Bureau is requesting that be added to the bylaws. Also, some of the training that Shelley got regarding open meeting law, that voting by email shall not be permitted. So we specifically added that to the bylaws. On page 3, under attendance, we've also added communication. Members must be able to communicate their attendance via voice, chat, or in person. Again, we want to make sure that we meet all the requirements of a public meeting. And I think those were all of the recommended updates to the bylaws. So thank you to those of you that participated in the work group to update this. Any questions or recommended adjustments to this? All right, hearing none. Anyone opposed to the proposed bylaws update as shared, please say nay. Any abstentions? All those in favor say aye.
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 Aye. Thank you. Next up under agenda items to be considered for the next meeting. Does anyone have any items that they would like us to include right now? Please feel free to speak up or share that in the chat. Otherwise, you can always email Shelley Bissell or myself for items to be added to the agenda for our next meeting. Next up is call to the public. Jim?
Dr. Bradley, first of all, thank you very much for the presentation for the 988. That was fantastic. Really appreciate that. And also, Dr. Garcia, for you bringing up the suicide prevention for the month of September, which is obviously been fantastic to be able to provide the awareness that's out there. For those of you who are not aware, about 10 years ago, we founded a nonprofit organization called EMShelp.org. So this is a nonprofit 501c3. And about a year ago, we expanded a awareness month to have our awareness launch for EMS Help. And we used the domain stopourstigma.org. So stopourstigma.org. And that website is up and live. There's a pledge for individuals to sign, and it's gone incredibly well. We received the opportunity to get 4,200 impressions through Clear Channel through the billboards in Maricopa County over this next year. We had 7.8 million national impressions when we launched the awareness for suicide prevention specific to the world of firefighters, EMTs, and paramedics. And those of you that aren't aware of the study that was done back when Dr. Ben Bobrow was still here, EMTs, paramedics, and firefighters have a 39% higher rate of suicide than the general public. And then locally, we've had 30 different media outlets, including 3TV and KOLD down in Tucson that ran live spots. 3TVs is actually next week. If you get the opportunity to see that, both Dale Krogan and Chief Brewster will be live on TV. If you guys want to make sure they buy ice cream. We have an event coming up for those of you that did not get my invitation and have a desire to go. This invitation went to every single fire chief in Maricopa County, along with fire chiefs in Yavapai, Pima, and Coconino counties. I did as far as reach as I could with the fire chiefs' email addresses that I had. The event is on October 4th. It's a senses, so you're smelling, touch, audio, visual on the senses and how those senses can be affected to improve mental health care for healthcare providers, first responders. And so it's a impressive group that's coming. We've got about 46 RSVPs thus far. For those of you who are interested, please reach out to me. I'd be happy to give you at the end here, I'll give you my cell phone number and my email address. If anybody has not received the invitation that would like to attend on October 4th at 3:30. And lastly, I wanted to say a big shout out and thank you to Tom McSherry. He's a board member of ours that just recently stepped down from our board. We had a little celebratory event earlier this week for him, thanking him for serving on EMS Helps board and Stop Our Stigma. And big thank you to Dr. Gil Bradley, Chief Rob Brewster, Chief Tom Dwiggins, Will Humble, Glenn Kasperzak, Dr. Mark Lieb, and Dr. Dea Rampersad to be our current board members, and how excited we are to continue to have them on our board. And just yesterday, we made the announcement of adding a new board member. His name is Dr. Nima Norami. He's one of the medical directors at Dignity Health. So with that, my email address is jim@jimhayden.com. And it's in the invitation from Shelley if you guys have an invitation for today. And my cell phone number is 602-803-5000. If anybody would like to go again to the event we're hosting on October 4th for the census presentation for mental health. That's it. Thank you.
Thank you very much, Jim. All right, next is a list of upcoming events. Those are in your meeting packet. We also have a list on the Bureau's website for news and conferences, as well as training program. Our next meeting will be held January 18th at 10:30 a.m. And if I can get a motion to adjourn.
So moved.
Thank you.